since we have so many options over here, if some patient was to get, say, docetaxel in the first 6 months approximately of starting androgen deprivation therapy for hormone-sensitive state, and then be followed out in time, and sometime in the future, obviously, that there will be cancer progression. At that time, it opens us the door to reuse either a re-challenge with docetaxel, which is a lesser preference actually, but to be able to use the abiratrones and the enzalutamide. On the other hand, if you give upfront enzalutamide or androgen receptor pathway inhibitors like apalutamide, like abiratrone, with androgen deprivation therapy for that length of time, and then they progress, which they will, then you've knocked off all the androgen receptor pathway inhibitors, and you are now going to be looking at docetaxel at this point as an option. So I think we need to figure out the best way to sequence this paradigm on an individual patient per patient basis. We will also have to look at the real world reality of how many patients are going to have access to these drugs, because they are costly. There was a cost analysis between abiratrone and docetaxel done in the hormone-sensitive state. It was clear that it is more cheaper, but then the side effect profile is slightly different and maybe a little more toxic than abiratrone. And so those are the weighing points that will have to be sort of utilized in the context of the patient in front of us as we go forward. We don't have good biomarkers. It would be really good to figure out if there were biomarkers that could teach us how to sequence this, but we don't have that right now.